All right, so it's 1 o'clock. My name is Mary Wiley, and I'm Executive Director with Niagara Connects, and we're really pleased to welcome you folks who are joining us today. I think there'll be a few more people coming into our Zoom meeting room. We're really happy to be hosting this webinar in partnership with Quest Community Health Center and the Niagara Helps project partners. So the topic is Peer Support Navigators, Easing Health Systems Navigation for Individuals Experiencing Homelessness in Niagara. And this is actually really groundbreaking work that's being done right here in Niagara. And so it's great to be learning more about it today. It feels a little bit like this is coming full circle because at the very beginning, some of the origins of this work came out of some work that at the time, McMaster University Brock campus medical students were doing. They were taking a look at a project that they could do to connect with community. And you'll be hearing a little bit more about that from Rahat when he's speaking later on. They took a look at the Living in Niagara 2014 report and the suggested action steps. And as most of you probably know, that report is our community's measure of quality of life, and Niagara Connects facilitates the preparation of the report. So out of that came the idea to take a look at the concept that is now being brought to life through the HELPS project. So that feels like we've had a little bit of a connection with it all the way along, and really pleased to be supporting this ongoing work. So without any further ado, I will, just a couple of housekeeping items. This webinar is being recorded. We're recording it so that we can provide an archive of the webinar as a resource to be posted to the Niagara Knowledge Exchange. You may find after you hear about this information that you'd like to share that archive with others in your networks. And everyone who's participating today and who registered for the webinar will receive a follow-up package with a link to the archived webinar and any supporting materials. And joining us today, our presenters are Shilpi Reina, and she's the coordinator of the Niagara Helps project. And we have Rahat Hussain, who is a researcher and also a partner in the project. And we have Scott Cronkright, who is one of the peer support navigators working here in Niagara. And I can tell you that this is a really powerful information these folks are sharing. You'll notice there's a couple of polls during the webinar, and so we'll just take a little pause for you to complete the polls. And there's one at the very end for you to help us evaluate the webinar in terms of the learning experience so that Niagara Connects can constantly improve on these learning opportunities. And without any further ado, we'll just ask you as we're going along, if you have questions for the presenters that come to your mind, please type them into the chat pod, and Rachel Gilmore will, who's also on the Niagara Connects team and helping to facilitate today, will facilitate the question and answer period a little later on. So I will now turn it over to Shilpi.
Thank you, Mary. Good afternoon, everyone. Welcome to the Niagara Helps webinar. First of all, I would like to say thanks to everybody who's taken time out from their busy schedules to attend this webinar. My name is Shilpi, and I'm the project coordinator for the Niagara Helps project. As you can see on the screen, the HELPS acronym stands for the Homelessness, Emergency Liaison, and Peer Support. You might be aware of a lot of programs like shelter programs and housing programs that are available for people experiencing homelessness within the Niagara region. And the objective of our program is also the same, to serve the homeless population in our region. However, there are two main ideas that make the HELPS a pioneer project slightly different from the other programs. First and foremost, we are using the lived experience of our peer support navigators to help individuals, and also we are implementing this project in the emergency departments at our hospitals. We will be elaborating on both these points later during the presentation. And before we get going, let me introduce to all the presenters that we have today. So we have Scott Cronkright, who is our peer support navigator and one of the very essential drivers of this project. We also have Dr. Rahat Hussain, who is a resident physician at University of Toronto. And the whole idea of the HELPS project was generated by him and his team at fellow researchers at McMaster University. And he'll elaborate further on how this idea was generated later. And then there's myself, and I'm the project coordinator of the Niagara HELPS project. Now, the HELPS project has been brought to life through the partnership between Quest Community Health Center, where I work, and also McMaster University. In this partnership, Quest is responsible for the implementation part at the ground levels, while McMaster University is in charge of the research component of this project. In addition, there were two very important partners that helped shape up this entire program. One is the Health and Equity through Advocacy, Research, and Theater, which is the HEART program, which basically works on improving and bringing equity in our healthcare system, as well as the EMRON, which is Emergency Medicine Researchers of Niagara. These both organizations have played a pivotal role in shaping up this entire program. Now, all this would not have been possible without the help of funding agencies that have helped us to bring this project. We received our initial funding from United Way, Niagara Community Foundation, and the Ontario Trillium Foundation. And this funding helped us to deliver this program 5 times a week for 30 hours per week for a duration of 1 year. We have just recently received funding from the Niagara Prosperity Initiative as well, and that has given us further opportunity to increase it to an additional 1 year and also provide services from 30 hours to 50 hours each week. I would like to now invite Dr. Hussain into the thing to take over the presentation. Rahat?
Hi, thank you so much. So I'll speak a bit to the origins of the HELPS project which started off really as HEART, and then I'll speak about some of the initial work that we did in getting things going, and hopefully there will be value there for others to kind of get a sense of what the lay of the land has looked like in Niagara when it comes to homelessness and emergency department care and use. So originally this project started as HEART, so as Shilpi had mentioned, Health and Equity through Advocacy, Research, and Theater. This was a project that myself and colleagues in medical school did back in 2016. The basic premise was to interview people experiencing homelessness about their experiences with healthcare, then take those experiences and create a platform for them to engage and innovate and improvise solutions to their own problems, and then to involve policymakers and decision makers and community members in moving those solutions forward. So we interviewed them, we took those interviews and turned it into a research-based theater script. Then we mounted a theatrical play during which people from the community could actually replace actors and try to solve problems in these healthcare settings that were based on their own experiences. And one of the ideas, the policy ideas that came out of this process of engaging the community and working around their lived experience was to implement peer support workers in Niagara emergency departments. In fact, I think I can still kind of flash back to 2016 when Scott, who will be speaking later, was avidly advocating in front of this group of about 40 people for peer support to happen in the emergency department. So from 2016 to now, that's exactly what we've been working on. Next slide, please, Shilpi. So we had lived experience on our side in support of this project. We had the idea itself, which came by way of the community in partnership with policymakers, including decision makers at Niagara Health and the LIN. But we actually didn't have a lot of information about the population that we were trying to help, what the situation actually looked like on the ground. So in the past year and a half, we partnered with the Institute for Clinical Evaluative Sciences, ICES, the provincial administrative data organization that tracks healthcare use across Ontario. This first graph here shows all of the visits to emergency departments by people experiencing homelessness and non-homeless folks in Niagara across all 3 of the emergency departments from 2010 to 2017. All of the data we had available that we could access from this provincial body. The main takeaway is that the line up top is the standardized number of visits by people experiencing homelessness. which has basically skyrocketed. It's a 6-fold increase over the 6 to 7 year period that we measured compared to people who are not homeless whose visits stayed about the same, maybe a few decimal point increase. So right away we knew there's something going on here. Emergency departments are not always ideal places for care outside of course, acute situations. And we could see that for whatever reason, people maybe were getting sicker or their needs were being met when homeless and they were coming back more and more frequently. Next slide. Then we broke it down, broke down the data into the 3 separate emergency departments in the Niagara region and looked at the number of unique homeless patients over the 7-year period. And so obviously you can see here that St. Catharines has had the greatest volume of people experiencing homelessness who present to the emergency department, followed by Greater Niagara and Welland. The key takeaway is that it's not just that people are visiting more often, but the raw number of people has been increasing, whether that's because homelessness in general has been increasing in the region, or people are migrating from other cities like London or Toronto to Niagara, or people are same number of homeless folks, but they're getting sicker, and so more and more of them are coming to the emergency department. We're not sure, and we're actually now doing additional research on migration patterns and healthcare status to try and figure this out, but it's very obvious just between the last slide and this one that more people are visiting over time. People are visiting more and more often. I can tell you, based on crunching the numbers, that the rate is something like 2.7 times the number of visits between 2010 and 2017. So there's been an increase, and we anticipate that probably in the last couple of years that has continued to be the case. So we knew for sure that there was a role here for something to help these folks in the emergency department. So then we broke down whatever we could using big data. We looked at what the experience of people actually was in the emergency department. We already had their lived experience. We knew it wasn't optimal, to put it that way. And that's really where the peer support work or the peer support navigators were supposed to come in. But even when we crunch the data, we see that people experiencing homelessness spend quite a bit more time, just about 2 hours more in the emergency department, 2.5 compared to non-homeless folks. And they spend about half an hour or so longer before they're seen by an emergency physician. So you've got these folks who are coming in more often. The numbers of them are increasing. They're having to wait longer in the emergency department for whatever reason, and it's taking longer for them to be seen by a physician. And again, that trend, especially for a period of time in the emergency department, had been increasing there for quite some time compared to those who are not homeless. So we knew that there's some unique issue here at play that hopefully peer support workers could intervene on and help. Okay. So I believe this is our first opportunity for a poll. And the question simply is, are you surprised to see the statistics, to see what the actual numbers are on the ground for people experiencing homelessness who need emergency care in Niagara?
All right, so we're launching the poll. And if you could please participate by answering. And we'll just keep an eye here to see when it looks like the activity is winding down for people participating in the poll. And when we do that, then we'll be able to show you the results. And by the way, these polls are anonymous. So I see there's still a few more people participating. And all right, so 88% of you have voted. So we'll end the polling. And there, can you see the results? I hope you can. Yes, I see some heads nodding there.
Yeah, so it looks like, 2-to-1 ratio. Most people, the majority, were not surprised to see the statistics. You know what? I'll be honest, neither was I when we got this data from ISIS. I think this is really where the use of the data was so key, is that certainly the people who lived through it knew this to be the case. People anecdotally have some sense that there's a healthcare disparity here, but the data really stood out starkly. Nobody had ever accessed this data before, and it gave us a real hot ticket item to get this project going. And then I wonder if anybody in particular wants to share their thoughts, perhaps in the chat, for those folks who were surprised to see these statistics. What about it was surprising? Maybe their background and context. Yeah, thank you though. Thank you for everybody for participating in that.
Thank you, Rahat.
All right,
Sorry, Mary.
No, that's good. On to the next slide.
Okay, so thank you so much, Rahat, for sharing all the data. I would like to now share some information about when we launched the program. So as I stated earlier, HELPS program was launched. It was launched on January 9th this year, and we started the implementation in the emergency department at the Greater Niagara General Hospital, which is in Niagara Falls. To explain it in simple terms, any person who's experiencing homelessness, when they visit the emergency department, one of the staff members advise about the availability of Niagara Helps program if they want to be part of this program. And if the person agrees to be part of the program, then the information is sent to the peer support navigator, like Scott. And from that point onwards, the peer support navigators assist the client during their entire stay in the emergency department. So Scott, who is our peer support navigator, will be sharing what exactly the services he provides when he's in the emergency department a little later. So the program ran successfully for about 10 weeks. And during those 10 weeks, we received tremendous support from the staff at GNGH. They were very welcoming and were always there to support our peer navigators. And some of the statements that they made us realize how important is the work that we are doing. For example, one of the registered nurses mentioned that the homeless people never seem to be able to get a break, and this idea seems to be very good. While one of the charge nurses said that this project is so different from what she has seen earlier because of the lived experience that we are using, because the peer support navigators who are helping implement this project have the shared lived experience that helps to remove a lot of barriers, communication barriers, and the ability to share their own experiences with the patients. So that helps, it makes patients feel very comfortable. They are encouraged to share their concerns openly rather than having a student explain all those things to the students. So their positive feedback about the program made us realize the importance of this pioneering work that we are doing. However, as we know, COVID-19 changed the whole world. So the project was put on pause after 10 weeks. But we have a wonderful news. Just yesterday, we received the approval from the ethics board, and we will be resuming our services very soon. Now, let me introduce you to our wonderful team. So it's a very small team of 4 people. It includes Dr. Hussain, myself, Scott, and Glenn, who are the peer support navigators. Unfortunately, Glenn could not join us today. And we also have some researchers from McMaster University and Brock University who assist and work alongside Dr. Hussain to take care of the research component of this project. Now, we have been talking about peer support, but what exactly is peer support? So it becomes imperative to explain what exactly is peer support. So in very simple terms, it's the idea of using the expertise of certain individuals to help cater the needs of a very specific population, which means in this case, Scott and Glenn, who are our peer support navigators, they have the expertise because of their lived experience. So they have not learned these concepts through books or through degrees. They have learned it by living it through their own lived experience. They know what it was like to be part of the population that they are now trying to serve and help. They have vast knowledge of which community resources helped them once, and now they can help by recommending those services. And most of all, they have true and genuine compassion to help people improve their circumstances and also be a role model, a success story to motivate others to work towards setting personal goals and also making a plan to achieve them. Again, Scott will shed more light into his own experiences with life and in the emergency department and why he decided to take on this task to become a peer support navigator. So what are we trying to achieve through the health program? There are so many objectives, but the very basic objective is just to make healthcare navigation easy for people for whom it can be a very daunting task. We want to make people feel at ease when they are accessing the emergency services. We also want to collaborate and build long-lasting relationships with the ED staff so that the peer support navigators can highlight underlying issues of homelessness, which people from general population might not even be aware of. So when peer support navigators share their own experiences with the ED staff or with the patients, it creates a sense of belonging. It helps to reduce social isolation that people experiencing homelessness feel, and it also increases their comfort with the healthcare system, which then ultimately leads to improvement in their overall experience in the emergency department. But most importantly, as I stated earlier, what our peer support navigators are trying to do is connect these individuals to available community resources that could prove to be highly beneficial to them because of their own experience of using those services. So without delaying it further, let me invite Scott into the conversation and then he can share his own experiences. Scott.
Thanks, Shilpi. Welcome everybody and good afternoon. And I just want to say what an honor it is to have this opportunity to share my story and our story about this amazing project. For me, from its onset, it has been life-changing and a big part of being able to continue to move along and helping others just like others helped me. I am going to be quite honest with my story and maybe a little brutally honest in some points, but I think it's very important that if I tell you that I share with you the entire backstory, it might give you a more of an understanding of how we're able to help, where the compassion comes from, and the direct understanding in developing and continuing the relationships with our patients in the ER. When I was between the years of 11 and 12 years old, unfortunately, I am the survivor of sexual assault by 2 faith practitioners over the course of 2 years. And that's going to lend itself to the story and understanding what had happened from that point on to as I got older and into my 40s. The sexual assaults completely went unattended. I had no therapy. They were put into the back of my mind, and I continued to try and grow and be part of society at that point. It was later on in my life that unfortunately I had some major surgery. And from that major surgery, I was in hospital for a long time and in ICU. I was discharged, and at that point I was addicted to morphine. This is not an uncommon thing for people whom before going into the hospital didn't drink, didn't use drugs, and we become addicted to the medical available opiates, and that's what led to the entire downfall. Over the course of 6 years, what I was diagnosed with was never lowered. It was a very high amount of morphine, and I became, from a successful businessman at that point, very involved in my community, to living in my basement and not seeing anybody, and very ill. And I woke up one morning, and unfortunately my house was empty, my wife was gone, and my children were gone. And I was homeless at that right then and there. The shock of the system overwhelms you at that point, where you reach out to whomever you can, and getting no's was very, very difficult. So that had a lasting effect as well. But all of a sudden, all I have is my car, and that became my new home. What I'd like to also share as we go down here is that I am a type 1 diabetic with a couple morbidities around kidney disease and a few other things, which didn't help being addicted to the morphine. And that led to a situation where I found out very, very quickly what it's like to be stigmatized going to the ER. So over that course of time when I was addicted, I had many, many trips to the ER. They got to know me. They got to understand what my addiction was all about. And it built up an initial stigma, in my mind especially, that if anytime I presented to the ER, I was being judged immediately on who I was, or pardon me, not who I was, but what I was. And that is somebody who's in active addiction. I got very sick, a temperature over 104. I was taken by ambulance from my car, which was parked down in Burgoyne Woods. That's where I was sleeping here in St. Catharines. And I was taken by ambulance and punted from the ER out to the waiting room. And my kidneys had failed at that point. And I spent 12 and a half hours out in the waiting room trying to lie down on a very small bench. And again, to be honest, I had thrown up and I was left for an hour in my own vomit. Once I was seen, I was diagnosed immediately and spent the next 3 weeks in hospital. This lended itself to some resentment and anger about how I was being treated and stigmatized because of my addiction rather than I had a health issue. But that went away very quickly on the onset of joining this program, working in the ER and understanding how the ER works. And I'll talk a little bit more about that a little down the road. Why I decided to become a PSN. First and foremost, to help others. During my recovery, it took an incredible team to put me back together. From all of the community resources in Casson and Carsa and Newport facility and on and on and on, and many people. It takes a village to help somebody like myself. Being part of a team and supported in this team and having that vision towards the future is absolutely huge in my opportunity. And I don't mean this selfishly, but to be able to give back in a way that I feel completes me. And again, in the support from Shilpi, who is an amazing mentor, and Rahat, being part of this program is forever letting me have the opportunity to grow as a person. We do take some courses. The lived experience piece is the big one, but we are provided with some wonderful education. And that launches us into the role of this expanding team within the ER. Unlike maybe other settings, it's a different beast. I have learned to be in the ER, maybe rather than being on a medical floor or in a group setting. It has some very many challenges in trying to understand and navigate between the staff and between the healthcare system and with our patients. And we walk a very fine line in trying to make sure that we represent and advocate for our patients, because of everything we do is patient-centered. That has always been, I guess, the baseline of healthcare, and that's what I've learned. And keeping in mind, also being able to increase awareness around homelessness with the staff. We have been overwhelmingly welcomed by the charge nurses, by the nursing staff, and by the doctors. And we've had some great opportunity to collaborate. And I'm just going to give you a couple examples here. They have allowed me the opportunity, anytime that an OD, an overdose comes in, I am consulted right away. If it is one of my people that we've dealt with, then I'm there to help. And as they go through their recovery, I'm able to be involved from the onset. That gives me a really quick step up in understanding that I can, having the background on that particular person and seeing them go through this step, I can help them in that area. The other thing with this program, I think that is going to be a great advantage too, is that we're going to be able to reduce the amount of code whites. So if we have a mental health issue amongst the ER, again, at GNGH, they would call me in just to consult to see if this is one of our prior patients or somebody that I knew from the streets. And then I can get involved after, you know, the reduction in tension and be on scene to help them out. I really truly believe this program is going to alleviate the need for security guards outside of their doors when they come in. I can't tell you what that feels like to be in that bed and know that everybody knows there's a security guard sitting outside your door. It only helps or it only challenges you the stigma that goes around and the feeling of shame and guilt that comes with being either homeless or suffering from an addiction, and especially mental health. What I'm able to do is to alleviate that security guard and stay with that patient from admit to discharge. It's an amazing opportunity. Also, that gives me the opportunity to build that trust relationship as soon as I get the chance to meet them. And it really de-escalates a lot of bad situations in which they come in with a chip on their shoulder, even though it's not warranted most of the time. But they do come in feeling the stigma and the eyes and being talked through and around. Very typical for our community. Now, just to close out on that particular section, the last thing that, and again, this is a little different from maybe other settings, but we have to learn what CTAS means. So for any of you who may know about triage, they were wonderful, wonderful collaboration in taking the time for me to learn what it was like what CTAS means. So I am able to go to my patients and explain to them, look, there's a reason why you've been given this number. Anybody who's a 1 or 2 is going to be, you know, taken first. Anybody like a 4 or 5 is going to wait quite a bit. I get the opportunity to educate them on how the ER works. It's not personal. It's not something they're doing. They are not being judged ahead of time, all the time. Some, in a very low example, there is stigma, and I'm going to talk about that. But this gives the opportunity for the patient to understand that it's not focused on them. It is part of how an ER works, how tough it is, how many patients have to go through. And that was a great advantage in the charge nurse, taking the time to say, you need to learn this and then implement it. Sorry there. If we can go to the next slide, if you bear with me, I've got a couple short examples of how we've been able to be effective in the ER. We had a young lady present. Now, she had a prior history. She's an IV drug user. She had many overdoses and been brought to the ER. They knew her very well. She had been living in a corridor at the casino. It was the only place where there was heat and electricity to charge her phone. She had injected opiates, which play a huge part of what's going on in the streets right now, meth and methamphetamine. And she had fallen down the stairs and presented at the ER with a sore leg and knee. When I was made aware of her, I got the opportunity to hear her story, and she was about to be discharged. And her leg was in bad shape. They had not x-rayed it. They had just done a visual. The doctor felt that she could be given crutches, and out the door she would go. I was able to advocate for her to the doctor, explaining that I thought, with no medical experience at all, and not thinking that I had any, but just advocating for that patient, that I think the injury was much more serious than what it was. And the doctor was wonderful and said, okay, let's take another look. The young lady had broken her leg, or fibia and tibia, and a cracked kneecap. She ended up having major surgery and was in hospital for another 2 weeks after being discharged from the ER. She went upstairs. This landed a great opportunity for us to help bring together all the community resources, those in the hospital and those outside the hospital. So in collaboration with another organization, the RAM Clinic here, we were able to get her the opportunity, the help she needed in pressing towards recovery, and getting help and going to detox, and then looking further and being followed during that process within the community. She went to detox, she went to treatment, and I don't know how she's doing right now, but I thought the outcome was absolutely vital, or pardon me, was directed towards all the opportunity of using all those resources within the hospital and all the resources outside to get her the help she needed. And the next fella that we helped had a suicide attempt. He was an alcoholic, again, had been to the ER before. He was given the opportunity, he was formed and brought in and was going to talk to the mental health team at the general hospital. I was brought on board and heard his story and had sat with him, and we talked, and it took an extra 4.5 hours to get him in front of the camera with the psychiatrist. And in that time, he became incredibly agitated. And he got up and left from the video room because he wasn't able to make the contact, and he walked out the door. Because he was formed, the police were called, and he was brought back in handcuffs. There was an isolation room at G&GH for patients like this. He was brought in and kept in handcuffs, and I was able to advocate at that point, really worried about him not being able to de-escalate, with the police looking over him, security guards looking over him, the curtains open. And I was able to advocate for him with the police first to get the cuffs off, to get the handcuffs off. And secondly, to have all security away from the actual site. And it became just him and I was able to use that opportunity to de-escalate the situation. This young man has gone on to full recovery. He is no longer drinking. He is in the letter. He's in AA and doing really well. Lastly, just to kind of sum everything up, if the best thing I can have you, we can go to the next slide, Shilpi. There's a few things you can do, and I'm sure a lot of you are service providers and understand what this is like. But if you could learn their names and have eye contact. Another thing about the ER that I've learned is that nobody gives you eye contact, because if you look at somebody, that means that you're available for a question. And because they are so busy and overwhelmed in the ER, it gets very overwhelming for them. For us, being not hearing our names, not feeling like we're part of the community is a big deal. It's really important that we use eye contact, and please use a lot of compassion and empathy, understanding. One quick point. I'm gonna leave you with this kind of idea. Again, being service providers, you probably understand that. For those who may not, when you wake up in the morning, what are the first 5 or 6 steps you can take without anybody holding you back, without having to worry about money? You can take a shower, have your coffee, get your breakfast, get dressed, use an iron, a washer, dryer. When my guys wake up, their first thought is, Where's my first hot meal? Can I brush my teeth? Can I wash? Can I eat? Can I get a fix? Where am I going to get the money for that fix? And the chaos that encompasses your entire day just trying to survive, the smallest things, a clean pair of socks, those are the things that give dignity back to those who are homeless. And being able to access healthcare in a safe and understood and compassionate environment is what we're doing. And we strive to do that all the time. Again, making sure that we are 100% patient-centered and understand that what I went through, you went through, and you're about to teach me more than I could ever teach you. Thank you for listening. And if you have any questions later on, I'd be more than free to answer.
Thank you, Scott, for those stories. Before we move further, we would like to gather your feedback on the question that is displayed on the screen. How do you think, after listening to Scott's story and people that he's been able to help, how do you think the Helps Project and the peer support navigators can help our community?
So we're just watching those poll results come in. We'll keep an eye on them until we get up to a really high percentage of participation. All right. So we're up to 84%. Going. There's your chance. And there are the results.
Thank you, Mary. So I can see all of you agree that we are trying to do everything, and it makes us so happy that you recognize what we are trying to do. We want to bring all the barriers and the issues that are faced by people experiencing homelessness to the forefront so that we can have effective discussions and we can come up with effective solutions to address those issues. And we want to bring awareness in our community, as Scott mentioned, right? Just learning their names can make such a huge difference in how people feel, right? The compassion. And we also want to achieve all this by a very simple concept, the lived experience of people like Scott and Glenn, right? It is just a very basic human compassionate perspective that he has shared with us. And how can you help? We are trying to do this, but there are several ways that all of you who are attending this webinar today can help. First and foremost, just simply spread the word, spread the information about this program, share it with your friends and family members and the organizations that you think either are not aware of these issues or maybe they might be able to further spread the word out in the community. Share this webinar. It will be available through Niagara Connect soon to be downloaded. So you can share this webinar with your friends, families, anybody you want. And also advocate for expansion of the peer support project. We want peer support to be an integral part of our healthcare system so that people who think they are being stigmatized or discriminated against have somebody to help them navigate healthcare system and voice their concern. And again, come up with solutions. So once again, thank you so much, everyone, to be part of this wonderful presentation today. On behalf of Quest and McMaster University and our entire team here, we would like to extend gratitude to you. And I also want to say thanks to the wonderful team at Niagara Connect who provided us a platform to share this information. It would not have been possible for us to reach so many people through this, through this one webinar. And I would like to bring in Rachel now to help us facilitate the questions that have been posted in the chat box. Rachel?
Hi there. I think most of the questions have been answered. Earlier, there was a few that popped up and Rahat was able to address them. But there is one I see here, and that was from Jeff Sinclair. And he wrote, wonder how the things about those who do access the emergency department compares to the health presentations of persons experiencing homelessness but refuse to go to the emergency department. Are there different health needs between the two groups? How might this peer support be leveraged to improve willingness of those who are avoiding the emergency department to choose to access it? There's a big one for you.
I can maybe start off with answering the first of the two questions there. And also maybe I realize in the recording of the webinar, the questions that I answered in the chat may not be accessible. So perhaps I can just reiterate those answers as well. But Jeffrey's question about are there different health needs between the two groups? Not that we know of based on research that is currently out there in the research literature. As you can imagine, it's very difficult at baseline to gather accurate information, timely information about the health needs and service needs of people experiencing homelessness. That said, the little that we know is that often they will visit an emergency department in the year that they pass away, which suggests that, potentially suggests that they may be quite sick by the time they actually finally present to the emergency department. Other than that, though, there isn't a whole lot else that indicates if there are different health needs, although I think anecdotally we all surmise that there are probably very sick people who don't go to the emergency department, especially until they very well can't help it. But turn it over to the others to add their thoughts and maybe answer that next question about leveraging peer support.
Rachel, can you repeat the question again, sorry?
I sure can. Okay, here, let me bring it up. Okay, so are there different health needs between the two groups, people who are accessing the ED versus those who aren't? How might this peer support be leveraged to improve willingness of those who are avoiding the emergency department to choose to access it?
So I can take up the third part of this question, and maybe Scott can answer the second because of his experience. So I think when somebody comes into the emergency department who had a negative experience, now is seeing that there is somebody who is helping them navigate. And when they go back and share their experience with other people in the society, other homeless population, it's again like spreading the word, right? So when they have positive experiences, they share their positive experiences with other people who are experiencing homelessness. That would then maybe motivate people to come into the emergency department, hoping that they will be able to connect to a peer support navigator and get improved or enhanced health care services. So does that answer the question? Good. Okay, Scott, do you want to elaborate on the second part?
Well, I agree 100%. We've had a couple of our those experiencing homelessness come back into the ER, and they're looking for that guy. So either myself or Glenn, they have heard and passed the word that there is extra help within the ER. And again, with what Rahat was saying, the issues inside and outside for our group are very similar, but the ones who do not access because of prior stigma or knowing that it's going to take all day, they won't be fed, things like that, will not access. So what would be maybe simple wound care will escalate into abscess and maybe sepsis, and they come in much sicker than they do when I think sometimes people would just access and have the ability to know that they have somebody who's there who's going to listen.
And I also want to highlight that it is one of the objectives is also to create leaders like Scott and Glenn, the advocates for this kind of program, right? So now that they have come out of those circumstances, now they are advocating for people experiencing homelessness. We might get more Scotts and more Glenns in our society being created through this program, right? So we are trying to break those barriers one step at a time.
Great, thank you. Rahat, I'll take you up on your offer. We had some questions earlier about, do you have a sense that the opioid crisis is impacting the number of ER visits? And you were able to give some information about that. So.
Yeah, and so that question, and then one from David Baskin as well about thinking about the correlation in 2012 between the increased number of visits and the beginning of the opiate crisis, kind of similar questions, so I'll lump them together. So we actually just earlier, either I'm losing track of time, but earlier this week or late last week, accessed data from ISIS, the provincial body, about opioid-related presentations, and we're just in the process of crunching that now with our team to get a better sense of what the impacts of the opioid epidemic have been on this population visiting emergency departments. That said, we do have already access to mental health and alcohol-related visits in the context of other complaints that might be bringing people to the emergency department. And we see that mental health by far is the biggest category leading to visits. It's 60%, and about 40% of that 60% is alcohol-related or substance use-related. So we already see that these chronic health issues are probably not being managed well in the emergency department, and we're just working on putting that information together and publishing and presenting it now.
Great. I see a few more questions. I have one here from Vinay. Thank you for the great talk and for sharing your stories. Reach Niagara has set up clinics at various shelters in the Niagara region to serve patients who are experiencing homelessness. This initiative helps to reduce the number of visits to the ER. Reach Niagara also collaborates with specialist physicians, nurses, and other healthcare workers, etc., for them to see patients. However, there are several challenges to this initiative, and one of them is the availability of resources to maintain the commitment of healthcare workers to serve these patients who are experiencing homelessness. What can Niagara Helps do to overcome these challenges? Are there talks of collaborations with organizations like Reach Niagara?
So I can maybe start us off on that one. So I work very closely with Dr. Carl Stobie, who's one of the directors of Reach Niagara. We're actually just putting together another research project to evaluate how people perceive the quality of care that they receive at Reach Niagara. We've been working on that for a couple of months now. But as to a more formal intertwining or collaboration between Niagara Helps and Reach Niagara, we haven't reached that point yet, but absolutely, I think in general, I'm going to speak a bit generally here, but the more you're able to make connections between these different services and organizations, the more powerful you become, the more you're able to address these problems at the many intersections at which they occur. So to your question about one of the challenges being maintaining the commitment of healthcare workers, that's really interesting. I've never actually thought about that. I'd love to connect. If you know Dr. Stobie, or I can type my email out if you just want to reach out. I'd love to connect around that and see how we can formalize things a bit more.
That's great. Thank you. The next question is from Cassie. Thank you for speaking so honestly, Scott. It's greatly appreciated. Do you often have more than one person that you are working with at the hospital at the same time? How do you manage that? And secondly, how open are the clients to participate in the research aspects of the pilot?
Good question, Cassie. First off, there has been one situation where we had 3 patients in at the same time. Our focus is to be one-on-one and stay consistent with that very first patient that we're working with. They're used to people walking away and not fulfilling their kind of contract and relationship buy-in. So Glenn and I have been able to come up with just an agreement that if we ever get in that situation, that either one of us can be called on the spot, and if we're available, we will rush in and try to take up the slack. It's very important that, I feel it's very important that we don't break that trust with the initial client. It's hard to juggle, very hard to juggle, and depending on where they sit as far as treatment, and this is where collaboration with the staff has been fantastic, is that I can find out if this patient's going to be discharged first, second, or third, and that will give me the ability to make a judgment call on whom I'm going to work with at that time. Secondly to that was I was not turned down, pardon me, the percentage of being turned down for the study was nominal. 5, maybe 7% of the people, I think maybe it's closer to 5 to 8% of the people said they didn't want to participate, and that was fine, but we had wonderful buy-in from all of them. And just to give the kudos to the patient, as soon as I was able to say, this is going to help out yourself and all the rest of us, made a huge difference in the buy-in in the study.
Okay, just a quick comment here, Mary Wiley here. We're going to let things go on a few minutes beyond two because these are great questions. I don't want to get in the way of them, but I think for those of you who are able to stay, I just don't want to cut those off. This is highly valuable.
Thanks, Barry.
Back over to Rachel.
I have one from Counselor Lococo and Ionani from Niagara Falls, and they're asking, what can council do to help?
I've been looking at that and thinking for a bit, but I'm curious, Scott, Shilpi, perhaps you folks are more operational than I am. You might have some ideas already.
From the city's standpoint, I understand that there's a great many challenges that the cities have to deal with, especially in needle pickup and a lot of the garbage that's left around. If it would be beneficial to try or to have some kind of maybe discussion, maybe some partnership in that area, letting us maybe explain how it is to be homeless and what the city staff can do, I mean, other than making sure that they're protected, maybe making sure that they are trained through positive living and especially the region on Narcan kits, things like that. But that's the only thing I can think of at this part, other than the support and maybe a funding stream.
Thanks, Scott. I would also highlight one thing here. So here I'm sharing the experience of Glenn, who is our other peer support navigator. So what hit him and why he decided to change his life was when he was released out in the cold in just the hospital gown. He didn't have any slippers on. So a lot of times what we have noticed is people are getting released and they don't know what to do. They have not fully recovered. It's cold outside. They don't have proper clothes on. They don't have shoes. So I don't know whether city would be able to help with, the discharge part, so that people have somewhere to go once they are released, at least until they recover.
Although that's also what we're working on, so maybe maybe in short order we'll be able to take care of that problem. Thank you so much, counselors, for your extremely kind offer. Also amazing that you're here and obviously interested in addressing these issues that are yes. very much a major factor in the Niagara region and growing in concern. So Shilpi had mentioned earlier that obviously we and also every other project in Canada were put on pause during the pandemic, and we've since made some changes during that time and have just received approval to start again yesterday. So we're going to be looking at a grand restarting as soon as possible, ideally within the next few weeks, certainly within the month. So it's a good news story all around, I like to think. We're sort of a born and bred in Niagara project funded 3 parts by Niagara-based organizations and 1 part by the Ontario Trillium Foundation, all run by Niagara-based people. I did med school there, close enough. So if there's an opportunity here to spread the word, perhaps through the media, good news story to show that we are innovating and tackling this problem, then I think that can have a lot of reach. Part of the changes we've made to the project, we are now going to be open to anybody who is experiencing homelessness and comes into the emergency department, and we have more hours of funding available to serve them. So we are more than happy. I think Scott is certainly very happy to work his keister off to help as many people as possible. And around the funding, so that's one thing, perhaps, if you're interested in connecting around arranging good, sharing the good news story around the project, if you think that's appropriate. The other thing is we're always hustling for funding, and we, depending on the grant and the organization we communicate with, sometimes it's helpful to have letters of support. So if that's something that you might be able to offer, that could really go a long way as well when we continue to apply for funding. Our ultimate intent is to have this adopted as part of the Niagara Health Team, one of the new Ontario health teams. But as I understand it, that's just getting up and running. We have some ins, but in the meantime, we hope to just keep it going until it becomes a permanent feature of healthcare. Hopefully.
And advocate PS upon navigation to be part of the healthcare system, ultimately. Just be permanent role being part of the Niagara health system.
Awesome. And I put my email out there. Maybe I'll just type it again because it can move up the chat real quick. But counselors, if you'd like to reach out, that would be amazing, or I might just reach out to you anyway. And then really anybody else, I see David Baskin, you've messaged about connecting the patients we see with Niagara Health's hepatitis C care clinic. That would be amazing. I think certainly Scott Glenn would be thrilled to make those further connections. Scott already referred to how he's been getting connected with the RAM clinics and other organizations. So the more we can do for the people we see, the better. So absolutely, that's something we can follow up as well. Lots to build on the foundation we've laid.
There's one last question. I think it's been a little bit answered, but I'll still ask it. From an anonymous attendee, does the project aim to educate hospital staff on ways to better engage and treat those whom are experiencing homelessness or substance use?
I think if I can, I'll take this.
Yeah, go ahead.
I didn't do as good a job as I wanted to in explaining how the collaboration with the staff, charge, and the medical teams has been. The charge nurses have facilitated some great huddles in which I was able to come in a short amount of time, very succinct, but tell the story of the homeless and explain how, what the day in the life of. I'm able to give them a face. And it shocks them because when they do not put the peer support together and find out that I was homeless and was addicted to opiates, they say, how can that be? And it allows me that opportunity to break that mold. And then one-on-one, every time one of the nursing staff gets one of our patients now, I'm brought in on the consult. And I can't tell you how valuable that is. There is pushback. There's a lot of caregiver fatigue, and you have to work around that. But most of the time, they are open and asking wonderful questions, wanting to be educated on what it's like to be addicted. What does that mean? And substance abuse. And it gives me that opportunity to have them increase the amount of empathy they're using, but also the community compassion and the piece in reaching out to other resources from their standpoint within the hospital and outside of the hospital for particular patients. Because I'm able to take a lot of time away from difficult patients, that time's freed up for that particular health provider to take a little bit of time, a little bit of extra time they probably don't get, and consult and work towards the betterment and for the patient, and keeping that patient-centered focus going. But they've been incredibly receptive and wonderful.
Right, so I'm going to step in here now. I think Shilpi has put her contact information there. That's the last slide, right, Shilpi? And
yes.
So our very last thing that we're going to ask you to do is we have an evaluation poll just on the quality of the learning experience. I want to say a heartfelt thanks to everyone who participated. And it is an honor to have had the opportunity to facilitate this webinar.